Good afternoon, everyone. I hope everyone is enjoying the conference, both for the people who are attending virtually, as well as the people who are in Naivasha. So my talk today will be looking at acne lookalikes and the things that we need to consider as the differential diagnosis when we are seeing patients who present with an acne-like eruption. So we look at the possible conditions that may present as acne as early as the infantile stage all the way to adulthood. So acne, as we are all aware, is a very common inflammatory condition that accounts for about 80% of the cases that we find in the outpatient dermatology consultancy visits. And what is important to note that helps us to differentiate these conditions that may look as acne is that they tend to lack comedones, which are the primary lesions that we see in patients presenting with acne vulgaris. So we need to be aware of these conditions, especially in patients who we are managing for what we may think is acne, but they seem to not be responding to treatment. So starting from the neonatal period, so there's a condition known as benign cephalic pustulosis, and this generally is a condition that where you'll have a neonate presenting with a predominant pustular eruption. So they'll have both papules and pustules, and they tend to be concentrated around the forehead area, the eyelids, and the chin. The neck and upper chest may also be involved. Again, you'll not see comedones, but in true neonatal acne, you will notice or you will be able to see comedones. And this condition tends to start around day 5 of life. And the causative organism thought to play a role is the yeast Malassezia fafa or Sympodialis. And the treatment for this is generally you can reassure the parents that it is self-limiting and it will usually resolve within a month. Or if you opt to treat, you can use topical azoles, such as ketoconazole cream, which you can use for about 2 weeks. The other condition that may present as acne in this age group is a condition known as sebaceous gland hyperplasia. And this tends to affect about 50% of term infants, and it is less common in those who are premature. And the characteristic findings are pinpoint, whitish yellow papules with no erythema, and they tend to be follicle-centered. Again, there'll be no comedones that you'll see. And the location in this condition is areas where you have a high density of sebaceous glands, and this will be the nose, the cheeks, the upper lip, and the forehead area. And this condition is thought to be attributed to maternal and fetal androgens, which act on the sebaceous gland. Again, this condition is self-limiting and does not require treatment. Another condition that you need to be aware of is a condition known as miliary, and this tends to occur in up to 40% of infants, and most commonly will occur on the face. Now, Epstein pearls are the miliary that you tend to see on the hard palate in the oral cavity. So this miliary will present as 1 to 2 millimeter white firm papules, which may occur on the face, but other areas may be involved, such as the trunk, the extremities, the genitalia, or the oral mucosa. And of course, you will not be expecting to see an acne-like true acne in areas like the extremities or genitalia. So the primary miliary seats are located at the pilosebaceous unit of the areas that have vellus hair. Now, when we move on to the adolescent age group, there's a condition known as Petrosporum Folliculitis, which is an important condition to be aware of. And this condition tends to present as an acneiform eruption, but these lesions present as monomorphic papules and pustules, which may be pruritic. And in terms of the distribution, which may help you differentiate from acne, is that these lesions tend to present mainly on the forehead, the chin, and the sides of the face, with sparing of the central face. Again, comedones will not be found. Other sites of involvement which can occur with acne include the chest, the back, and the shoulder area. And of course, these are areas where there's an increased density of the sebaceous glands. And this condition is thought to arise as a result of an inflammatory response to Malassezia species on the skin, which overgrow and thrive in the sebaceous environment. And of course, it is commonly, again, found in the adolescent group due to an increased activity of the sebaceous glands. Now, this condition may also overlap with acne. So you may find a patient who has both the Petrosporum Folliculitis and acne, because both of them are associated with follicular plaquing. How you would probably diagnose this condition is you can take a sample of the papule or pustules and do a KUH examination where you'll see numerous spores of the yeasts. So antibiotics tend to, if you use antibiotics for this condition, or if you put a patient on antibiotics, you'll notice that their acne either tends to worsen or does not seem to be improving. And these patients will probably, or will put them on a course of oral antifungals, and they tend to respond quite well. So another condition that you need to be aware of is granulomatous perioral dermatitis. And this condition tends to present with flesh-colored, pink, or skin-colored papules around the mouth and the eyes in the pre-adolescent age group. And there's usually sparing of the vermilion border. So precipitating factors in this condition will be long-term use of topical or oral corticosteroids. And again, comedones will be lacking in this condition. So if you're not sure if a biopsy is done, what you would find are superficial and deep dermal non-caseating granulomatous infiltrate, which is centered mainly around the hair follicles. So the treatment for this condition would be your oral tetracyclines, for the anti-inflammatory properties. If it's in an age group where you cannot use the tetracyclines, then you can opt to use your erythromycin. And topically, you may use your calcineurin inhibitors. Another condition to be aware of are angiofibromas. And Acuteness angiofibroma is a benign vascular neoplasm that is composed of dermal fibrous tissue and blood vessels. So angiofibromas can be acquired, or they may be part of a genetic syndrome. So the genetic disorders that are characterized by the presence of angiofibromas are conditions such as tuberous sclerosis, or it may occur, as we said, it may be acquired, as in patients who have the polypenile papules. So the angiofibromas may be solitary, as seen on the image on the right, or they may be multiple. So this is a patient with angiofibromas due to tuberous sclerosis. And tuberous sclerosis is a neurocutaneous autosomal dominant syndrome. And these angiofibromas begin to appear in childhood around the nasolabial area and on the central face. And other areas where you can find angiofibromas are in the periangle area of the nails. And when they are found here, they are called Conen tumors. And facial angiomas associated with tuberous sclerosis are also described or called adenoma sebaceum. And this condition may be associated with systemic involvement, where they may have kidney, brain, eye, cardiac, or lung involvement. So management of these angiofibromas are mainly cosmetic. So topical rapamycin may be used, lasers, or radiofrequency. But the problem with it is once they are removed, the recurrence or the rate of them growing is high. So another condition to be aware of now, moving on to the adult age group, is a condition called Fabry-Rochat syndrome, where patients present with solar comedones and pseudocysts, which occur as a result of sun damage to the skin. And so other than seeing these comedone looking lesions, you'll see features of sun damage, such as this solar elastosis, leathery skin, and deep furrows. So basically, the treatment here would be sun protection, topical retinoids. You can also consider things such as chemical peels, which would be beneficial, would be both anti-aging and would help with the comedones. Another condition to be aware of is eruptive vellus hair cysts. And this usually presents as small papules containing vellus hairs. And they usually tend to be found on the central chest. They may be familial, so there may be a family history of such a condition. And usually they present as erythematous or red or skin-colored papules over the sternum. They have also been reported to occur on the lips and the vulva. So the diagnosis is not sure, because also a condition that may appear like this is eruptive. When you have patients who have, I'm forgetting the name, but I'll remember it. But if you want to do the diagnosis, you do a skin biopsy where you see stratified squamous epithelium with a granular layer surrounding a cystic space. So management is that most of these tend to disappear by themselves in about a quarter of the children affected, and individual lesions may be removed surgically by excision, curettage, or laser. So another condition we need to familiarize ourselves with is rosacea. And this is a chronic disorder that presents, a chronic inflammatory disorder that presents with a variety of cutaneous or ocular manifestations. And in terms of the skin findings, what you'll find is that this patient presents with erythematous papules or pustules, mainly on the central face, and they'll have persistent centrofacial redness, as seen in this patient with the image on the right, and they may have telangiectasia or rhinophyma. So in our skin type, features such as erythema and telangiectasia may be masked. So that is something important to note. But if you do dermoscopy, you may be able to see the telangiectasia, or you can do diascopy, where you use a glass slide and press it on the erythematous area to see whether they'll be blanching or not. So the other presentation that patients of course complain about is burning sensation on the skin, flushing, or dry appearing skin. So rosacea occurs commonly in adults over the age of 30 years, and it's more common in females. It may be mistaken for acne, or it may also overlap in patients who have acne. In the patients who have acne as well, overlapping, you may find comedones as well. And then again, ocular involvement may manifest with lid margin telangiectasia or redness of the conjunctiva. So the management here, topical, if you're using topical treatments for mild cases, you may use topical metronidazole or topical ivermectin cream. In patients with moderate to severe disease, then you opt to use oral tetracyclines for the anti-inflammatory properties, or macrolides in patients who cannot use tetracycline. And also oral isotretinoin or retinoids may be used in patients, especially in patients with phymatous changes. Laser and Intel's pulse light may also be used, especially in patients who are presenting with telangiectasia. So another condition also to consider is a condition known as Keratosis, Polaris, Rubra faciae. So again, as from the name, the patients will present with papules which are centered around the follicle, and they tend to be quite scaly and rough on palpation. And it's a common manifestation that may be seen in children, adults, and in the adolescent age group. And what you'll see are rough red symmetrical patches on the skin, mainly on the cheek. Then again, typical keratosis pilaris, as we know it, when associated with patients who have atopic dermatitis, will also present on the back of the arms and the thigh area. Another condition to be aware of is pyoderma faciale or rosacea fulminans. So these patients present with an intensely inflammatory purulent facial plaques and nodules with draining sinuses on a background of erythema. A history of rosacea may or may not be present, and young females tend to be commonly affected. So we can appreciate that they are, you can see this erythematous plaque that is raised with the studded pustules on it. But again, comedones tend to be lacking. Another condition to be aware of is gram-negative folliculitis. So this will commonly occur in patients who've been on antibiotic treatment, long-term antibiotic treatment while on management for acne. And these patients tend to present with erythematous pustules and a few papules on the face, and most commonly on the perinasal area. So as from the name gram-negative folliculitis, the common organisms implicated are your Klebsiella, Proteus, or Enterobacter. And if you want to confirm whether this is the case, you can take a swab and do a gram stain of one of the pustules, and you'll see this gram-negative, you'll stain gram-negative bacilli. So the management in these patients would be use of isotretinoin. Istinophilic folliculitis. This is a condition that is characterized by pruritic, discrete erythematous papules, which may be urticarial, and it mostly commonly occurs in areas such as the scalp, the face, neck, and upper trunk. These are areas with a high concentration of sebaceous glands, and it may be endemic, as in seen in Japan, and in this case it would be called Ofuji's folliculitis, or it can occur in patients with advanced HIV. And on biopsy, what you notice are perifollicular infiltrates of lymphocytes and eosinophils. So this is an image of a patient who had eosinophilic folliculitis, and other than having that, they also had the stavudine-induced facial atrophy. But you can see the papules and pustules on the face of this patient, and this is on the image on the right is of a patient with more inflamed papules and pustules on the face. The last condition we'll mention is lupus miliaris disseminatus faciae, and this is a rare condition affecting the face primarily in young and middle-aged adults. Clinically tends to present as monomorphic yellowish brown papules appearing on the center of the face with a predilection to the periocular area. And of course, comedones are typically absent. Diagnosis is established by doing a biopsy, where you'll see well-defined caseating granulomas with multinucleated giant cells and epithelioid cells. So spontaneous regression with mild scarring is the expected course. This is a patient with the same condition. So basically, you can appreciate the inflammatory papules and pustules on the malar area. And usually, again, comedones tend to be lacking in this condition. So the only way to be sure of if you're managing a patient with acne and they're not responding would be, if you're to rule out this condition, would be a biopsy. So thank you for your time, and I hope you enjoy the rest of the conference. Thank you.